Hello and welcome to our first Frailty podcast. My name is Jo Shaw. I'm the operational lead for Frailty, and I'm joined today by Dr Helen Alexander, who's the clinical lead for care of the elderly, Lauren Evans, who's our Trainee ACP for Frailty, and finally by Dr Sangeeta Kulkarni, who's our clinical vision of flow lead for Frailty. So, to start, what is clinical frailty?
Thanks, Jo. I suppose a good place to start is what isn't frailty. So it isn't disability, it's not just simply ageing, and it's not someone who's just taking lots of medication. It's a different to normal ageing. We can identify it, we can measure it, and we can prevent it. It's an accumulation of multiple health issues which lead to a state of vulnerability such that even a minor illness can have major consequences. So on a positive note, though, minor fixes can have major impact. So a frail old patient can feel a little bit like they're walking on a tightrope, whereas a fit person, they can feel like they're walking on a wider footpath. So a gust of wind would not alter their situation, but for a frail older patient, a gentle nudge in a frail person can have disastrous consequences unless you grab a support at the right time.
Thanks, Helen. So our next question is, how do you spot it and how do you measure it?
Thanks, Jo. You can't just look at a person and decide that they are frail. You need a diagnostic tool to confirm a heart attack or a hip fracture. In a similar fashion, you need a tool to measure clinical frailty. There are several, but we have adopted the Rockwood Clinical Frailty Score, as the majority of the trusts in this country have. It is a 9-point scale, 1 being fit and 9 being terminally ill. It is a validated tool to assess clinical frailty at an individual level. It is important to recognise that an older person may appear far more frailer when they are unwell or on a hospital bed or trolley. They may not have eaten or had a very lack of sleep, and all the things that unfortunately happen when someone gets admitted to hospital. Therefore, it is recommended that the score is based on their ability to look after themselves 2 weeks prior to falling unwell. The scale is available on EPR and conveniently included on our ED clinical assessments and clerking documents so that members of staff are not reliant on their memory or guessing. We encourage all patients over 65 to have a clinical frailty score recorded on arrival. It takes a few minutes. Patients with a higher scale of 5 to 9 have a higher risk of hospital admissions, admission-related complications, worse outcomes after sepsis, major trauma, infections, operations, invasive procedures, both routine and emergency. Therefore, it applies to all adults, specialities, both medical and surgical. The importance of adding a clinical frailty score to a patient's past medical history and dating it allows us to spot increase in frailty over a specific time frame and what may have contributed to this increase in frailty.
Thanks, Lauren. So moving on, so why should we use a clinical frailty scale?
Thank you, Jo. So after listening to Lauren and Helen, if people are still not convinced, there are 5 reasons why we recommend measuring a clinical frailty scale. Number 1, it helps us to recognize that not all older people are the same. You may have an 85-year-old who still works, drives and goes to the gym 3 times a week. This is your clinical frailty score of 1 to 3. Or you may come across an 85-year-old who may require little or all care to manage their activities of daily living. That's your clinical frailty score of 6 or 7. So second reason, it offers a very succinct and elegant way to convey health information. It speaks a language that is understood by our primary care and SWAST colleagues. It is a term that could be used by nurses, therapists, nurse practitioners, physician associates, and doctors. The third reason is it instills good practices and prompts taking relevant functional history that can be gathered in a very short time. We gather data at a trust level as to what proportion of patients we document a clinical frailty score on. And it's a good measure of how we approach patients who are frailer and older. Number 4, it helps us to set reasonable goals of care. For example, if a patient with a clinical frailty score of 6 or 7 has finished their acute episode, in order to get them back home, they may not have to walk more than a few paces. Whereas someone with a clinical frailty score of 1 or 3, they may have to do a lot more. So they may need to go to a community hospital or need some rehabilitation. And finally, higher degree of frailty requires a different approach to someone with a lower degree of frailty. If you have someone who has a clinical frailty score of 1 to 3 and they've come in with pneumonia, you would admit them and offer them oxygen, antibiotics and fluids. Whereas treating pneumonia in a clinical frailty score of 6 or 7 would require a closer attention to bowels, bladder, nutrition, mobility, cognition and medications. And there is a term for this. It's called as a comprehensive geriatric assessment.
Thanks, Sangeeta. That sounds like our next podcast, potentially, a subject to cover. I just wanted to close with, if people wanted to learn more about the clinical frailty score, where could they look?
They could approach any of the frailty team. You might see them in ED or on the frailty unit, or any of the care of the elderly consultants. We are also developing a web page we're hoping to upload lots of useful resources.
Lovely, thank you.